Attachment-focused therapy is still a relatively new and emerging field, which has evolved and continues to evolve as research provides new understandings of the myriad of issues involved in attachment disorder behaviors. Attachment-focused therapy increasingly represents a comprehensive continuum of various models and techniques that are guided by an overarching set of principles grounded in attachment, child development, and trauma theories and research.
First, when we have a child who has difficulty trusting their primary caregivers, our primary goal is to help that child develop a secure relationship with their caregiver. Therefore, we almost always have parents and children together in therapy. And we are working on the relationship, not on the individual psychological problems of one of the pair who are with us, or the trio, or the many people who may be with us in therapy.
Many of the problems that we see with children who have attachment problems are really rooted in fear. And so it's very important for the parent and the therapist to help the child learn how to regulate. And part of the way to do that is, first, we have to regulate the child. Then we can do it with the child. And finally, the child will internalize that and learn how to regulate themselves.
One of our primary goals in therapy is to help a child who did not learn how to manage internal states, how to manage behavior, how to manage their attention, help them learn how to regulate all those things. Those are things that children usually learn in the first 18 months of life. And many of the children who've had disruptions of attachment or losses or traumas really never learned those skills. Or what they learned was to behave in ways that were quite unpredictable and difficult for others around them to manage. So we work very hard on regulation in therapy. That means we are watching the child's cues, that they are beginning to get upset, that they are beginning to get silly and maybe crazy, that they are beginning to get angry. And when we see just the beginning of that, we try to step in immediately to help them calm down, refocus, stop being overwhelmed by the difficult questions that are being asked, or whatever it is. This requires a lot of our effort in therapy to just address this one question, which in most therapies is never addressed. Secondly, we really have to work with the child and the parent to help the child replace skills they might not have learned when they were younger, skills of managing themselves, their behavior, their attention, and skills of relating to other people. And finally, we really have to address their trauma that they've experienced when they lost important people, or when they were hurt, maybe when they left a country that they had known from birth. Each of these goals is a big goal for a young child and their family. And although we talk about a phased approach in therapy, we really are talking about continually addressing these different areas of treatment. And it's usually quite a lengthy treatment.
I don't think at this point in time there's a significant amount of research that would say that we have a completely evidence-based approach to therapy. And I think the reason why not is because most people who have been doing attachment therapy are therapists and clinicians and not researchers. And I think in most fields, the practitioners and the practice has led research after enough work is being done so that the research can examine what is being done. It would be pretty hard to have research on something if there wasn't a practice model or practice models that were ongoing, so that there'd be enough clients to look at. And I think evidence-based, that language right now is quite trendy, and certainly there are people who wouldn't think that that's the most expeditious and the simplest way to go. Yeah, I think we're seeing, especially if you embrace the information being talked about in terms of a developmental trauma disorder, or complex trauma, we see that the kids we're talking about have multiple levels of trauma, multiple and sequential and simultaneous traumatic events going on. And so I think it's going to be very complex to ferret out all of the specific details for a specific kind of child's trauma and to match that with a specific treatment intervention. I think it has to be individually tailored and developed for each particular child. There are kids who have sad responses to their trauma. There are kids who have angry responses to their trauma. There are kids that are fearful based on their trauma. And I think we have to have an understanding of that context before we can just say we're going to do A, B, and C. And I think there are many children who are being misdiagnosed today, particularly with, I think, most often the inappropriate diagnosis of bipolar disorder for every child who has any kind of dysregulation or any kind of regulatory disorder. And that diagnosis was never really intended for children and adolescents. But then that particular diagnosis leads us into needing to have a medication regimen to do that treatment, which those medications haven't been approved for use in children and adolescents, and brings on a whole other set of physiological difficulties. So I think we need to get somewhat back to the basics of seeing what trauma has occurred and the child's response to that trauma and the child's subjective interpretation of that trauma, and not the clinician or the parent's interpretation of the trauma, because some kids have had traumatic events to which they have not had a traumatic response yet. They may later on, but what seems traumatic to me, the child may have somehow managed or mastered and accommodated to, and it may not be, their responses may not be in response to what I perceive their trauma to be.
Trauma disorders occur as a result of relational trauma in the child's early caregiving experiences. In attachment-focused therapy, we focus on the child-parent dyad. So in most cases, the parent and the child are very much intimately involved in therapy, and quite often we begin with the parent to help the parent understand the long-term consequences of early trauma and neglect that their child experienced. As the parent becomes educated in not only just the implications of what happened in their child's development and their child's ability to function in a relationship, the parent then is taught skills to become an integral partner in the therapeutic process.
Therapy to address the problems of attachment and attachment-related trauma need to include several key ingredients. One of them is affect regulation, which simply means teaching children about their feelings and how to manage their feelings. A second key component is to address distorted beliefs that children have developed out of the experiences that they've had. Experiences or beliefs about themselves, about other people, and about how the world works. And probably the third component is the teaching of what we would call pro-social skills, knowing how to build relationships, how to repair relationships, how to demonstrate empathy, because that is a teachable skill.
In attachment-focused therapy, the parent is a partner with the therapist in the healing work that the child does in therapy. The parent will learn therapeutic parenting techniques to become sensitive, responsive parent to create a secure attachment for their child.
Probably the most essential process to helping children heal is for the therapist to be helping the parent. Essentially, whatever we would like the parent to do with the child, the therapist needs to be able to do with the parent. And in this instance, what needs to happen is the therapist needs to help the parent feel a sense of safety and security and develop a secure base in their relationship so that the parent can help the child feel safe and secure and experience the secure base that the parent is creating. Well, it's very important for the therapist to support the parent and for the parent to really feel that the therapist understands them and is providing empathy and appreciates their difficulty. That then will allow the parent to understand the child and support the child by providing acceptance and nurturing and providing an environment in which the child can feel safe and unconditionally loved.
Absolutely. Absolutely, and we get many calls from people saying, my daughter's 12, is she too old? And the oldest person we've seen in our practice has been a 23-year-old who really initiated treatment by herself and brought her family with her for treatment. So I don't see an age when I would just say that it's hopeless, particularly if the person is saying they want to make the kinds of changes that will help them live more comfortably.